Hello everyone. We will wait a bit for people to join. Welcome to the webinar. Okay, so I guess we can start. Welcome everyone to our webinar. The topic today is an update on genetics and clinical management of tall stature. I want to thank MTG5 for organizing this webinar. If you all have questions, you can ask them in the question box in the upper right corner. All questions usually are answered at the end. So without further ado, I will introduce our chairs who will introduce the speaker. Susan O'Connell and Charlotte Hoyby are today's MTG5 chairs. So I will give the floor to Charlotte to introduce Lars.
Thank you and welcome to everybody. And I would also like to welcome Lars Sävendahl, who is Professor and Chief of Pediatric Endocrinology at Karolinska University Hospital and Institute. And he is also Scientific Director of Astrid Lindgren Children's Hospital, also here at Karolinska. He holds a position as Senior Consultant in Pediatric Endocrine and Metabolic Diseases. Lars Sävendahl has studied the growth plate for many years, and his research group has developed a new experimental models and has showed how height growth is regulated at the cellular level. The research results are being translated into different methods for treating children and adolescents with abnormal height growth. So today, Lars Sävendahl will give us an update on genetics and clinical management of tall stature. Please, Lars.
Yes, and thank you again for the kind invitation. Next slide, please. These are my disclosures, nothing of relevance to the presentation. So next one, please. So tall stature is the topic today, and world's tallest man, Robert Wadlow, 272, died at 22 years of age due to septicemia. Here is a picture of him and his foot size. Next one, please. So this is the outline here a little bit. Etiology, workup, treatment, outcome data, and some take-home messages. So next slide, please. So the definition of tall stature, a classical definition is a height about 2 standard deviation above the mean growth curve or more than 2 st above the mid-parental target height. And extreme tall stature, the definition is a height above 3 standard deviations above the mean or more than 2.5 above target height. So when to do the initial workup? Well, usually we say if the height is above 2 st above target or more than 2.5 above the mean, or if there is a growth acceleration during pre-pubertal years, you need to ask yourself, is there an underlying etiology? Next slide, please. When talking about etiologies, classically, we divided tall stature into constitutional tall stature, you have tall parents, or idiopathic, which means we do not know yet. Next, please. And today we divide tall stature into primary growth disorders and secondary growth disorders. And the primaries, we have sex chromosome aberrations and the different syndromes, where Marfan syndrome is the most common one here. And next slide, please. And then we have the secondary growth disorders, where we have hyperandrogenism, pubertas praecox, gigantism, or acromegaly when you have fused your growth plates. And then we have other causes like hyperthyroidism or obesity. Next one, please. So what about etiologies behind tall stature? This is a paper from Helsinki published a few years looking at tall stature in girls and boys. And as you can see here, familial tall stature or constitutional tall stature is by far the most common cause in both sexes, more than 50%. Then we have non-familial idiopathic tall stature, and on top of that, we have the different syndromes and secondary causes. Next one, please. And among these unknown box here, probably we have many genetic causes. Next, and I should say that in this study from Helsinki, genetic workup was performed in 28%. And next slide, we'll look at the results here. And in these 28%, which is the top of these two bars, if we have the next slide, please. Next slide, please. In this top 14%, a primary or secondary growth disorder was found. And in this histogram on the x-axis, patients are categorized based on how tall they were. So from to the left, those who had a height standard deviation score less than 3.3, and to the one to the right, where the height standard deviation score was above 3, plus 3.9 SDS. And you can here clearly see that the taller you are, the more likely it is that you have an underlying syndrome. If we look at the far right bars here, the extremely tall patients, Marfan syndrome, Sauter syndrome, and also syndromes with sex chromosome anomaly are the most common causes, the more dominant causes. If we look at the less tall patients to the left, we have the majority of them have a secondary cause, and most commonly premature adrenarche or precocious puberty or other secondary causes. Now something happened here on my side. I cannot see any slides any longer. Now I can see the slides again. And in this paper published a year later, sorry, next slide, please. Could we have the next slide, please? Here we go. So here we have the data in another study of patients with tall stature and developmental delay. This is one of the important parts of the medical history to find out whether there is a developmental delay and why. Because if you have a developmental delay and tall stature, approximately 50% of the patients have an underlying genetic cause, as you can see in this pie chart, where the most dominant is Sauter syndrome and other epigenetic regulatory genes. We have PI3K, AKT pathway genes, and some other genes found in many of these patients. Next one, please. Next slide. So this is to challenge you a little bit. Most of you directly see what this is. What do you think about the underlying diagnosis? We give you a few seconds here. You can see a high arched palate, always looking to the mouth. You have a positive thumb sign and long fingers, and you have a flat feet and pectus here, carinum. And next slide, please. And this is, of course, Marfan syndrome, which is one of the more common primary underlying causes of tall stature. And when performing DNA testing, we find a mutated fibrillin 1 gene, chromosome 15, is dominant inheritance. And approximately 25% of these patients have a de novo mutation. In other words, none of the parents have Marfan. And the incidence is approximately 1 in 10,000. Next slide, please. And Of course, Marfan syndrome, the follow-up is extremely important. We will not have time today to go through, but this table shows how Marfan syndrome patients should be followed up at regular visits throughout childhood and throughout adulthood. And of course, very much focus on cardiac, ophthalmology, musculoskeletal, and also genetic counseling, lifestyle, and importantly, the transition to adult medicine. Next slide, please. So what about workup? Next slide, please, in tall stature. Next slide, please. So in the workup, the family history is very important, of course. Ask for cardiovascular and other disorders, get growth and pubertal data in the family, pregnancy, birth information, information about developmental delay and cognition, of course, very important. Growth chart, oxology, Tanner stages, pubertal stages, any dysmorphic feature. If you have a dysmorphic feature, the likelihood of a genetic cause is much, much higher. Any musculoskeletal abnormalities, joint laxity, for example, spinal deformation, suggest a primary genetic cause. Neurocardiovascular ophthalmology, lab test, genetic workup or gene panel or karyotype if there is suspicion of a specific disorder. In childhood, we always do a bone X-ray and assess skeletal maturation and final height prediction, and I will come back to that. Next slide, please. So final height prediction, left-hand X-ray, and before we did the manual assessment, Grealish pile, Bailey-Pinot tables, or the Tanner-Whitehouse method. Since I would say the last 10-15 years, most hospitals in the Western world use different computer-assisted software. The Bone Expert is the most commonly used, at least in Europe. The downside is that there are no really good prediction tables for extreme tall stature or syndromes associated with tall stature, where we know that Bone Expert may underpredict and manual assessment may overpredict final height. Personally, I use both the manual method and Bone Expert, and often the truth is somewhere in between when it comes to the final height prediction. Next slide, please. And this is the Bone Expert and how final height predictions are made, taking into account the parental heights as well. Next slide, please. So I published together with Sabine Hanneman from the Netherlands a few years a flow chart of the assessment of a tall child. And this can give you some help in the pediatric patients. And the trigger here, if you see the second box here, is whether you have any dysmorphic features, mental retardation that gives a suspicion of a syndrome associated with the tall stature. And if we go to the left side, the second important question is whether the patient is proportionate or disproportionate. If the patient is disproportionate, there is a high likelihood of a syndrome, for example, Marfan syndrome. If the patient is not dysmorphic, there are other syndromes like the Sävendahl Fragile X that are more likely. If we go to the right hand side of this algorithm here, and if there is no dysmorphic feature, the next question to ask is whether there is a recent growth acceleration. If the answer is yes, then the next question is there any sign of puberty? If there is, then the answer is most likely precocious puberty. If no, you need to start thinking about pituitary gigantism, hyperthyroidism, or obesity, which we know drives growth. If there is no recent growth acceleration, the far right of this algorithm The question is whether the patient is extremely tall or not extremely tall. And if the answer is no, most likely constitutional tall stature. If yes, we need to start thinking about very, very rare disorders like estrogen deficiency or resistance or familial glucocorticoid deficiency. So this could give you some help. Next slide, please. So coming to treatment of extreme tall stature. Next slide, please. This first question always to ask is to treat or not to treat. And my first question to the families and the patient is to clear out who wants the treatment. Is it the parents or the patient or someone else? How effective is the treatment and how safe is the treatment? And also discuss cost benefit and ethics. Next slide, please. So coming to treatments, two possibilities are available, either hormonal or surgical. Hormonal, 6-hour treatment, more than 5 decades experience. We'll come back to that. And surgical, where we have almost 3 decades of experience of the surgical method, bilateral percutaneous epiphysiodesis. Next slide, please. So coming to the outcome data, next slide. Starting with 6-hour treatment, next slide, please. Classically, treatment in girls was given 28-day cycles with ethinyl estradiol in combination with medroxyprogesterone. Side effects, weight gain, nausea, headache, thrombosis, and as also has been reported, increased risk of cancer. And finally, and most seriously, decreased fertility and premature ovarian failure, as we'll see. Next slide, please. The benefits of 6-hour treatment in girls, high-dose estrogen. Here's a plot. X-axis is bone age, and Y-axis is the effect of the treatment. And positive means that the final height was reduced versus prediction. And as you can see, the effect is not very large in girls, and the treatment must be started very early at an early bone age to be effective. Next slide, please. Coming to side effects, this is a report from Australia on high-dose estrogen treatment in tall girls and the long-term fertility. As you can see here in this plot, treated versus untreated. On the y-axis, you have the accumulated chance of conception, and on the x-axis is the time in months. Over 1 year, there was a significantly reduced chance by more than 50% to get conceived or get pregnant over 1 year. So this was the first report. Next slide. Later, this has been followed by studies from the Netherlands. Next slide, please. If we have the next slide, please. From the Van Waal group, showing the a dose-dependent reduction of a probability of conception. Here we see a similar plot, 2 years treatment with high-dose estrogen, either 100 or 200 microgram ethinyl estradiol per day versus untreated. And on the y-axis, the probability of conception. And as you can see, it's a highly significant reduction in the probability of conception, and the effect is dose dependent. What was also found was premature ovarian failure and an earlier menopause in these women. So definitely a decreased fertility in high-dose estrogen treated females. Next slide, please. Furthermore, we reported from Sweden increased risk of cancer in patients treated with daily ethinyl estradiol and comparing treated and untreated. Next slide, please. And the data showed a significant increased risk of melanoma and also a clear trend towards increased risk of overall tumor in high-dose estrogen-treated patients. Next slide, please. So what about boys? Hormonal treatment there has been very high doses of testosterone enantate, double the supplementation dose, 500 milligram every other weeks, and twice as often. So it's 4 double dose in total. Side effects, acne, aggressive behavior, and some troublesome erections. The efficacy here in boys is less than in girls. Next slide, please. And as reported from the Netherlands, you can see a similar plot here. The treatment needs to be started at very early bone age to at least have some effect, meaning reduction of final height. And the effect is very minimal. And please observe here, if the treatment is started late or too late after 14 years of age, bone age, you may even risk making the boy taller than originally predicted. And the reason is, of course, you get an initial growth spurt when you initiate high-dose testosterone treatment, which overcompensates what you achieve by an earlier fusion of the growth plates. Next slide, please. So what about fertility in males? Similar plot, data from the Netherlands, probability of conception over 12 months, and there was no significant difference between males and females. There is a lower sperm count, however, in treated males, but so far no data on reduced probability for conception. Next slide, please. So then switching to surgical treatment, which we initiated here in Stockholm almost 30 years ago. Next slide, please. Procedure called percutaneous epiphysiodesis is done under full anesthesia, X-ray translamination, and a small cutaneous incision drill into the growth plate, the physis, and extraction and removal of the growth plate cartilage. It takes about 1 hour. The surgery performed both in the distal femur and the proximal tibia and fibula on both sides. Next slide, please. Postoperatively, load of the body weight, okay, directly after the surgery, no athletic activity during the first weeks after surgery. Next slide, please. We reported safety data here published less than a year ago, and as you can see, that the reduction, predicted final height minus final height, highlighted in the red box here, in girls at the top and boys in the bottom. The treatment was much more effective in boys, reducing final height by 8.6 centimeters versus 3.6 in girls. And these data, quite similar, have been also reported from the Netherlands. So more effective in boys than in girls, the surgical treatment. Next slide, please. So looking at body proportions, and this plot shows the predicted height, remaining growth in solid black to the left. And then you have the increase in height after surgery. The third column is the increase in sitting height after surgery. And the fourth column is increase in leg length after surgery. And as you can see here, both in girls and boys, the treatment was very effective, essentially stopping the growth of the legs, and just the upper body segment was growing after the surgery. Approximately 35 to 40% of the remaining growth was reduced by the treatment, more effective in boys. Next slide, please. There was a negative correlation between the bone age at the time of surgery and achieved height reduction. Very similar plot and data as with hormonal treatment. So the earlier you may start or have the surgery, the more you reduce the final height. But both in girls and especially in boys, the treatment is more effective than hormonal treatment. Next slide, please. So this is body proportions, and of course, in all patients, you can see the spaghettogram here. The sitting height percentage was increased after surgery. So for each line here, you see to the left, sitting height before surgery and then at 18 years of age. There was a minority of patients, and mostly in girls, that had a slightly increased sitting height than the normal. Next slide, please. What about leg length difference? Here you can see the leg length difference between before surgery and at final height. And not a single patient had a leg length difference exceeding 2 centimeters after surgery. And you can see here, the distribution. So there was no significant difference between pre and post operatively with regards to leg length. Next slide, please. What about safety and complications in these 70 patients that we published last year with up to 25-year data? One patient had a minor bleeding, one subcutaneous infection, which did not need to be treated with antibiotics, and a temporal peroneal palsy in one patient. Pain in about 38% of the patients. What about angulation? No increased hip, knee, ankle angle in any of the patients compared to preoperatively. Next slide, please. So to summarize, the epiphysiodesis surgery is an effective and safe method to reduce final height in extremely tall boys and girls. And the desired height reduction was greater in boys when performed at a younger bone age. And however, although no serious complications were identified, we still recommend that all patients undergoing this procedure are followed up in a structured way to early detect any rare complications, allowing timely treatment. Next slide, please. So if we compare the surgery epiphysiodesis versus hormonal therapy, first focusing on the surgery, the advantage is that you can wait until closer to adult height, and it results in more normal leg length. Most tall patients have relatively long legs. The downside is you get a small scar laterally above and below the knee, and potentially there is, of course, a risk of anesthesia, infection, and asymmetric growth. What about the hormonal therapy? Side effects I mentioned, side effects as weight gain, increased blood pressure, reduced fertility, and an increased cancer risk. So next slide, please. I will give you finally a few take-home messages. So first, always clarify the underlying etiology of tall stature. And if it's not familial tall stature, clarify if this is a primary or secondary underlying cause, and be very generous with genetic workup. Secondly, critically evaluate the bone maturation, and finally, final height prediction, and use automated software here. Clarify who wants the treatment. Is it in the patient's interest or someone else's interest? And would the treatment be effective? And this is, of course, very much related to the bone age and how much remaining growth. And finally, high-dose estrogen treatment should no longer be used for the reasons mentioned. 3 times more difficult to conceive and increased risk of cancer. And by that, I apologize for the technical problems, but we have at least 10 minutes left for Q&As. So thank you for attending.
Thank you, Lars, for your very excellent presentation, and it's an interesting topic. I wonder if there are any questions. Then maybe I can start with a question. For the hormonal treated patients, do you think there's cancer screening or surveillance required in the longer term, like when they get adults and so in the young adults?
It is a very good question, and we have discussed this with the ethical council in our hospital, and we got the advice not to approach these women for two reasons. When it comes to fertility, there is, of course, you could advise to save eggs earlier on, but most of these patients treated with high-dose sex steroids, they have already passed their fertile age. When it comes to cancer, the advice was just not to do anything because the risk is not that much higher, and it might cause a lot of anxiety. However, I must say that it's very common that tall women, their children, they come with their children to our clinic, and I always mention this to the mothers who by history have been estrogen treated, and encourage them to start their mammography screening at least 45 years of age, and if possible already at age 40, to detect any breast cancer, and also be very cautious using sunscreen. It's a quite dramatically increased risk for melanoma, and it's unclear what the risk is. If this is socioeconomic factors, tall individuals tend to have a better economy and higher university degree, and maybe travel more and spend more time in sun. And if you are taller, your skin area can be twice as large. And one hypothesis is that the more cells you have exposed to the sun, the higher the risk is that one cell get mutated and you eventually end up with a melanoma. So there might be different reasons. So be careful with the sun and use sunscreen, and attend your mammography screening if you have been treated. I should also mention, I didn't show the data, and we have published that tall stature per se is highly associated with increased cancer risk. For every 10 centimeters, the increased risk is 19% in females and 14% in males. But in opposite, you are protected from cardiovascular disease. So altogether, the average lifespan is not very different, irrespective of whether you are short or tall, with the exception of the very, very extremes. And of course, if you have an underlying syndrome like Marfan syndrome, you have a lower life expectancy. I should also mention that don't forget the parents in your diagnostic workup. We have every year a parent diagnosed with Marfan syndrome, thanks to the fact that their child has been diagnosed with Marfan syndrome, and it can be saving lives also for the parents. There is a question here about gigantism. I couldn't read that.
Would you like me to read it, Lars? It's Adrian Day in Liège, Belgium, saying, lovely talk. We deal with acrogigantism mainly and use neurosurgery, medical therapies that are not used for other forms of tall stature. But patients can have resistance to medical therapy. I was interested in knowing if you have experience with epiphysiodesis in males with pituitary gigantism. And also he'd like to know, so that's one question. There's another then after, I'm not sure if it's from him, but maybe you could answer that. Do you have any experience of epiphysiodesis in males with pituitary gigantism?
Yeah, so two questions. One is aromatase deficiency, and it is well known that that is linked to tall stature. And of course, in such a patient, is just to treat with sex steroids, and you induce fusion of the growth plate, and the patient stops growing, and you don't need very high sex steroid doses there. And the second question was surgery in a patient with a pituitary tumor. Yes, we have had 3 patients in total here in Stockholm with pituitary tumor coming to us for epiphysiodesis, and all of them had been treated with pegvisomant with some success, but as an additive treatment, added epiphysiodesis to limit the further growth. So it can be done in combination, yes, but still it needs to be done at a bone age. I would say preferably when you have at least 15 centimeters of predicted remaining growth, because as I mentioned, the predicted reduction or the average reduction is about 1/3 of the remaining growth. You can just stop the growth of the legs and not the upper body segment, and by the end of the puberty, the upper body segment grows a little bit more than the lower body segment. So don't wait too long if you have a patient with a pituitary tumor and rapid growth and unfused growth plates.
Okay, there's another question, Lars. I've turned off my camera because I'm having some technical issues. It's a question regarding estradiol valerate as an alternative to ethylene estradiol for tall stature. And also, the same person is asking, do you recommend using octreotide in treating acromegaly?
Yes, octreotide, as I said, I'm not treating acromegaly, and Charlotte is probably the right person to address the question regarding the use of octreotide in acromegaly. My experience is extremely limited there. So I don't know if you would like to comment, Charlotte.
Yes, you can use octreotide or longer-acting somatostatin analogs for treating acromegaly or pegvisomant, as you mentioned, Lars.
There has been studies in children and a few case reports years ago with octreotide, a lot of side effects. So it's not really a treatment recommended in children. And also the efficacy was not very good. So the problem often when you treat with something like octreotide, which has side effects, is that you are not persistent. If you give something to block growth, you need to do that until the growth plates are fused. Otherwise, you get a rebound, catch-up growth, and you will have no effect. The same with pegvisomant. You need to be persistent, right, with the treatment.
Thanks, Lars. Can I go back to that question there about the using estradiol valerate as an alternative for ethanol estradiol for tall stature when you're doing your hormonal treatment?
Sorry, I didn't really get. I got estradiol, but I didn't really get the question. Could you repeat, please?
Pardon, I'm having some issues myself with my connection here. Can you hear me?
Yes.
No. Yeah. There was a question about giving estradiol valerate as an alternative to ethanol estradiol for tall stature.
Yeah, if I got it right with related to estradiol treatment of tall stature, I think the data are very clear that you should not use estradiol to limit growth in tall stature. Don't exceed the normal substitution dose. It seems to be harmful in the long run for the girls. And we haven't discussed as much of ethics today, but there is a clear trend in Sweden and at least in the Western world towards more acceptance of being extremely tall. The demand for treatment has come down substantially. We have also increased the cutoff for making the treatment available in Sweden. Today, it's 190 centimeters in girls as a predicted final height and 204 centimeters in boys. And it's very, very few patients that undergo this surgery. So you should be very restrictive of offering treatment in very selected cases. And don't forget to find out if there is an underlying cause behind, most importantly, genetic cause like Marfan syndrome.
Yeah, I think that's a very good point, Lars. There is a question here whether you recommend a psychological evaluation to identify patients who genuinely are motivated to undergo treatment for tall stature, and should you have a second opinion from another pediatric endocrinologist when it comes to these treatments for tall stature?
It's a very good question, and I strongly advocate involving a psychologist because, and often it's the parents that need psychological support rather than the patient, because I would say that at least in 70 to 80% of the cases, it's more the parents that are driving this treatment in children and adolescents rather than the patient. And of course, then you should never consider the treatment. So this is always the first question I ask the families and the patient is actually who took the initiative to the workup and the referral.
Okay, great. And two more questions, and I think maybe in the interest of time, we'll probably draw to a close, but just conscious that we did have a late start. So the second last question is, do you recommend an oral glucose tolerance test in tall stature in children? And what results would you consider positive for this?
Of course, if there is a risk that this might be a growth hormone producing tumor, that is the golden standard oral glucose tolerance test. It's a very difficult diagnosis to make in childhood. Having said that, it's an extremely rare underlying cause, and it's random IGF-1 and growth hormone is not very, the specificity is not very high, so that is the test to be done.
And what, if you do use an oral glucose tolerance test, what results do you consider positive? I guess what's your cutoff? Do you complete suppression, or do you have a cutoff number for growth hormone?
Yes, we have cutoffs, but it depends on a lot, and I cannot give you the exact figure here on top of my mind right now. Sorry for that.
Sure. That's okay. That's okay. I guess it depends on the assay as well. And the last question then, thanking you, regarding undiagnosed, where you've stated they must be genetics cases. Do you have a protocol how often you would reanalyze the genomic data? And I think one of your first slides, you nicely said idiopathic is we actually don't know yet. So I guess that question is speaking to the fact that these genetic tests are evolving and we're finding out more and more about these rare conditions. Do you have like a turn? Do you look back after 5 years, or is there much yield?
Of course, I think it's very good to revisit and the underlying diagnosis, and obviously there are many undiagnosed syndromes and genetic causes in extreme tall stature. I know in our center, many other centers, this has now become routine to be very liberal with full genetic workup. Often a genetic panel focused on genes known to be associated with tall stature. It's always an ethical issue when you do these genetic screenings, and of course you need to discuss with the family before. I cannot hear anything longer.
No, I think it's 6 o'clock now, and if there's no more questions.
It seems like there are 10 questions or 10 people attending here, but it's 6 o'clock now. No more questions.
I think that was a very good indication of how well received your talk was, Lars. You just stayed to wait to listen, even it was a bit delayed by, through no fault of your own, and apologies to everybody and to yourself for that ending, but I think it was well worth waiting for. And the quality and variety of questions indicate that too. So thank you so much for your time. That excellent talk.
Yeah, thank you.
Thank you. Thank you very much.
Bye.
Bye. Thanks. Bye, everybody. Thanks.